Alrighty, we're going to go ahead and get started. We had a little bit of a schedule change, so Dr. Sharma has agreed to come and join us today, and he's going to give a didactic on pulmonary hypertension, and it's excellent, so it's going to be great. We're going to start with introductions, and then you guys are welcome to ask questions, or if you have any case questions or anything like that. So let's see, Caitlin Grados, do you mind to start introductions for us? And you might be muted, and if you have any trouble, you guys can always chat us.
Hi, this is Nicole Donahue. Caitlin's here. She's just in the bathroom.
No worries. Thank you, Nicole. All right, and Brandy?
Good morning, Brandy Bell. I am a respiratory therapist at one of Grayson Dorney's pulmonary rehabs in Lincoln County, West Virginia.
Perfect. Thank you, Brandy. All right, Grayson?
Yes, I'm Grayson Dorney-Koppel. I'm blessed to be the president of the Dorney-Koppel Foundation, and I'm delighted to see all of you this morning.
Perfect. Thank you. All right, and Sam? Sam Giordano? Can't seem to hear you this morning, but that's okay. Just feel free to chat us in. Beth Hudspeth? All right, no worries. Erin Erb?
Hi, good morning. Erin Erb, the cardiopulmonary director at Armstrong Hospital in Armstrong County, Pennsylvania.
Perfect, thank you. All right, and Dr. Weissman?
Good morning, David Weissman from Nash.
Perfect, thank you. And Mitra?
Hey guys, it's Mitra with Project ECHO. Thank you.
Thanks. All right, and Dr. Sela?
Good morning, Allison Sela from Preston Memorial Hospital. I'm the the director of the pulmonary rehab there. We're a Grayson Dorney pulmonary rehab site, and I'm also the pulmonary consultant for this group.
Great, thank you so much. All right, we did have some chat-ins. So Krista Critchfield and Krista Clark, both from Cabin Creek, Grayson Dorney Pulmonary Rehab there, both respiratory therapists. And then Sam chatted in. He is having some mic troubles, but that's no problem. We have a phone number ending in 3422.
This is Diana from the Pennsylvania model.
Great, thank you for joining today.
Thank you.
All right, and Dr. Sharma, do you want to introduce yourself?
Absolutely. Good morning to everybody. I'm Dr. Sunil Sharma, and I'm the Section Chief for Pulmonary Critical Care and Sleep Medicine here at WVU. And I'm happy to be this morning with you. Looks like there's a whole variety of audience, including respiratory therapists, pulmonary directors. And that's what I wanted to do, was to give you a little flavor of pulmonary hypertension. Now, this is not a disease you see every day, but it is a fatal disease. So having some kind of a general background information about it would be very helpful in your overall evaluation of pulmonary disorders.
Perfect. Are you ready if I share your presentation?
Go ahead.
Great. You just let me know when you want me to move to the next slide. Oh,
sure.
Except we're starting at the
bottom.
There we go.
So as I alluded, that pulmonary hypertension is a rare disease, although a lot of common conditions like COPD, obstructive sleep apnea, even some of the heart failures have what we call a secondary pulmonary hypertension, which is primarily driven by the main diagnosis, but does add to the comorbidities and mortality in this disease format. So today I'm going to be focusing mostly on group 1, which is the pulmonary hypertension or pulmonary arterial hypertension as we know about it. And move to the next slide, please. So one of the objectives of this is early recognition of pulmonary hypertension is extremely important, and I'm going to talk a little bit about that. Then I'm going to talk a little bit about how do you evaluate and look for pulmonary hypertension. And then last but not the least, how do you recognize pitfalls in the diagnosis of pulmonary arterial hypertension? Next, please. So let's start with a fresh case I saw last week, and it will give a certain perspective to all of you. So this is a very nice lady, 70-year-old I saw last week, has many years history of COPD, was recently diagnosed last year with obstructive sleep apnea and obesity hyperventilation, and not only is on a regular regimen of inhalers, but is on very high oxygen of 5 liters nasal cannula at home. And the reason she was referred was despite being compliant with the medication, she continues to remain quite dyspneic, short of breath, just walking 2 or 3 feet home. And that was very unusual considering patient was so compliant with the medication. In fact, patient was diagnosed with obstructive sleep apnea OHS, and since February of 2020 that I could look at the compliance data, she had been very compliant on her BiPAP, which was a high setting of 17/13 centimeter water with 5 liters of oxygen bled in. So something didn't fit right in that situation. Her New York Heart Association class, of course, was very advanced at 3B. And what got my attention was that she complained that she felt a little dizzy with exertional activity. Now remember that she was barely able to walk a few feet in the first place, and she's getting dizzy even with doing this minimal exertional activity. Her PFTs were done actually earlier this year. I was not privy to the previous PFTs, which were probably done in an outside facility. But if I can go through some of the basics of the PFTs in her case, her FVC was 2.28, which was 76% of predicted. FEV1 was not too bad, also at 1.8 liters to 72% of predicted, and the ratio was 76%, not necessarily screaming COPD at you. And looking at her total lung capacity did not suggest any underlying restrictive lung disease. Her residual volume was slightly elevated, which suggests some hyperinflation. But I would like to take your attention to diffusion capacity, which was only 46% of predicted. And I knew looking at this PFTs that something is not right, because this to me looked like a more isolated diffusion capacity defect than a very, very advanced COPD. And lo and behold, with the chest x-ray not showing any significant emphysema and the CAT scan also being normal, I did not think that this all dyspnea and hypoxia was related only to COPD in her case. And this case kind of highlights why pulmonary hypertension is so important, is because a lot of it get hidden with these comorbid conditions, including COPD, asthma, obstructive sleep apnea, coronary artery disease, and we rarely think about this disease as a primary disease. Next slide, please. Next slide. So having said that, since I wasn't convinced that this was all COPD, we went on and did an echocardiogram. And this is a snapshot to show you what we see. On your left side is a normal looking left ventricle. You can see how round, nicely shaped it is, and you can see the 2 papillary muscles in between the cavity. But on the right-hand side, you can see how the left ventricle, one side of the wall, is compressed and it's almost looks like a D-shaped septum. And this is what happens when you have severe pulmonary hypertension. The right ventricle is under tremendous pressure that it starts pushing the septum towards the left ventricle. And that's what we saw in our patient, which was not consistent with COPD or obstructive sleep apnea or obesity hyperventilation syndrome. calculating the right ventricle systolic pressure, we calculated her PA pressures, or her pulmonary hypertension pressure was 78 millimeter mercury, which is quite high. Let me remind the audience that the normal RVSP is around 40 or below. And of course, her ejection fraction was normal at 60%. So at that point, we decided that we needed to confirm this diagnosis and understand the hemodynamics. So over the weekend, we moved her to the ICU and put a right heart catheterization, or SWAN as some people call it, and look at the mean pulmonary artery pressures was 42 millimeter mercury. Again, in right heart catheterization, the mean PA pressure of 25 and above is consistent with pulmonary hypertension, and this is definitely way above 25, so this is in the category of severe pulmonary hypertension. Her wedge pressure was 14 to 15 centimeter water, which of course is below the threshold for what is needed for secondary pulmonary hypertension or group 2 pulmonary hypertension. Her cardiac output was 5.6, and her pulmonary vascular resistance was 5 Wood units. Normal is anywhere from 2.8 to 3 Wood units. And while we had the SWAN inside, we gave a challenge of nitric oxide to the patient, and the patient did not respond, which was consistent again with group 1 pulmonary artery hypertension. Next slide, please. So why is pulmonary hypertension important? As I alluded, it has a very high mortality. We'll show in the subsequent slides what it does mean to have a pulmonary hypertension and a high mortality. The other important part is that a lot of folks sometimes forget that we have 12 FDA-approved medications, and every day more discoveries are being made. So there's significant advances in the treatment and management of pulmonary hypertension, especially the group 1. And number 3, and the last important part, is that early detection is very important. And that is one of the reasons I highlighted this case from last week, was that this case probably had pulmonary hypertension all the way along, but had been misdiagnosed with COPD, and most likely missed because of that reason. Patient could have been treated much earlier when the patient's pulmonary hypertension was mild. Next slide, please. So this is a little quick question, a teaser, if you may say. From the onset of symptoms to diagnosis, the average delay in the diagnosis of pulmonary hypertension is 6 months, 12 months, 18 months, or more than 24 months. So most of you would be surprised that the answer to this is D, that it takes almost 2 years for the diagnosis of pulmonary arterial hypertension. Next slide, please. So this is the largest registry called the REVEAL registry in the United States, which keeps an eye on diagnosis of pulmonary hypertension throughout the country. And as you can see, the mean time between the symptom onset and diagnosis is 2 years in this registry. So very sobering figures that these patients remain undiagnosed for a very long period of time, and that is extremely detrimental for their prognosis as well as their health. Next slide, please. And with this graphs, I want to bring to your attention on the left side, you're going to see the original study performed by the NIH in the early 90s looking at pulmonary hypertension. And you can see by age 3, 50% of the patients with hypertension would have died. So if somebody is diagnosed with pulmonary hypertension at age of 40, 50% chances are that they may not be around to see their 43rd birthday. So very, very sobering, statistics. And on the right-hand side, you see that with the onset of new medications, treatment profile, and management of pulmonary hypertension, that survival has improved in this decade. Next slide, please. just reviewing a little bit of the pathophysiology as to why this even happens. So usually the pathophysiology and the mechanism of pulmonary hypertension lies in the endovascular bed of the pulmonary vessels. So the endovascular bed gets damaged from a variety of reasons, and that causes smooth muscle proliferation and fibroblast enlargement, and eventually it distorts the pulmonary vascular bed, causes significant obstruction, increase in pressures, and then eventual collapse of the right ventricle because of these very high pressures. The end stages of the pulmonary hypertension, if you can see the cartoon on the right-hand side, is a plexiform formation, which almost looks like a tumor in the pulmonary vascular bed. Next slide, please. Again, going to another question in the teaser, which one is not a presentation of idiopathic pulmonary arterial hypertension, shortness of breath, generalized weakness, syncope, ascites, or hilar adenopathy? So this question highlights how do these people present? And the answer, correct answer is E. Very rarely, if at all, patients present with hilar adenopathy. That is not the usual presentation of pulmonary arterial hypertension. Next slide, please. The clinical situation and the symptoms which these patients present with are mostly shortness of breath, fatigue, weakness, angina, syncope, and edema. And you can see that my primary care colleagues over here, the respiratory, even pulmonologists, these are symptoms we see on a daily basis in our clinic. There's nothing unique about it. And that's one of the reasons why we think that the diagnosis in pulmonary hypertension is quite delayed, because these symptoms could be anybody which you see in your clinic with COPD, with asthma, with coronary artery disease, and your first suspicion would be, well, let's treat that disease, and then we'll come back to it. And what happens is, as several months go down, they get labeled with that disease, and people tend to forget that these symptoms are not resolving, or this could be pulmonary hypertension. So this is one of the unique features about pulmonary hypertension. There's nothing unique about this disease as far as the symptoms are concerned, and it gets easily masked by other common disorders. Next slide, please. There are certain drugs which have been implicated in pulmonary hypertension. Most of you may be aware, in the early 90s, there was a weight loss medication called fen-phen, and a lot of people took that for weight loss. And even in the last couple of weeks, I saw at least 2 people who came to my PH clinic who had actually taken fen-phen. It's been such a long time that a lot of people forget about it. And unless you have directed questions towards it, most folks will not volunteer that information to you. So it's very important to ask these patients if they had ever been on their weight loss medications. Some other ones which are commonly implicated in pulmonary hypertension is cocaine. Black Beauty is another form of weight loss medication, which is a street drug. Dasatinib is anti-tumor medication used in CML. So all of them are actually implicated in pulmonary hypertension. Going back to it, a very important aspect of asking these patients is to know what drugs they have been exposed to in the past or currently. Next slide, please. So anytime you have a patient who has symptoms which just don't match, or they look very benign in sense they look like COPD, but they're not getting better, one cue is to know what are the risk factors of pulmonary hypertension, and does your patient has any of these risk factors? And that helps guides us quite a bit to saying, could this patient have pulmonary hypertension? Am I missing a diagnosis over here? So especially people who are at risk for pulmonary hypertension are one who have connective tissue disorder. So patients who have scleroderma, lupus, rheumatoid arthritis, a mixed connective tissue disorder. These are 50% of the people in the United States with pulmonary hypertension. So it's very important to pay attention to connective tissue disorder, ask questions pertinent to that, and ascertain if this patient could be having a connective tissue disorder, and could these respiratory symptoms be a form of presentation for pulmonary hypertension. Another patient population at high risk for pulmonary hypertension is HIV, and so is advanced liver disease. A lot of patients with advanced liver disease that have called portal pulmonary hypertension, and this is also a group 1 disease and amenable to treatment. Exposure, as I alluded to, weight loss medication, aminorax, fenfluramine, dexfenfluramine, they're all implicated in pulmonary hypertension. It's very important to understand and elicit that history. It's common these days for younger people to be exposed to drugs, including cocaine and amphetamine abuse, and these have been implicated in pulmonary hypertension. Of course, on a rare occasion, congenital heart disease like VSD and ASD can cause pulmonary hypertension. These we see mostly in immigrants who have not been screened for these congenital heart disease, which is kind of rare to find in the United States, but you get once in a while a patient from Mexico or outside South America who has not been screened and then presents straight with pulmonary hypertension. Next slide, please. So the best screening tool that we have for now, if you have the slightest suspicion that this patient's symptoms don't match, this doesn't look exactly like COPD, or there may be mild COPD, but the symptoms are out of proportion to the underlying COPD or asthma or coronary artery disease, the best thing to do is to get an echocardiogram. And in the echocardiogram, you're looking at the right ventricular systolic pressure, as I alluded earlier in the chart, and you're looking at the right side of the heart with the right ventricle and the right atrial anatomy and seeing whether these are within proportionate size as compared to the LV. And you're looking at the TR jet. So right ventricular systolic pressure of 40 millimeter mercury or more should raise red flags, and you may want to know why these pressures are so high. Next slide, please. So why do we consider echo only as a screening tool and not a diagnostic? Well, as my mentor used to put in, the road to hell is paved with normal echoes, is that many echoes can be falsely positive and they can be falsely negative. There are also limitations to getting a good image for patients who are obese, patients who may have underlying COPD, some hyperinflation in the lung. The echo signal becomes extremely weak, and it's not very easy to evaluate the right side of the heart, which falls partially beneath the sternum. And a lot of time, people who do echocardiograms may not even mention about the RV or the RA. So it's always important to take this in context. Many times when the pulmonary hypertension gets very severe, the pressure is actually falsely normalized. So an echo may show a normal TR jet, although the patient has very severe pulmonary hypertension. So for that reason, we consider this as a good screening tool, but not necessarily a diagnostic tool. Next slide, please. So another teaser over here. Let's say you suspect pulmonary hypertension. The echo does suggest that those pressures are high. And how would you evaluate? What would you get as the next step? Would you get PFTs, high resolution CAT scan, right heart catheterization, VQ scan? Well, you know, most of these are very important in their own domain. You obviously want to know that these pulmonary pressures are not elevated because it's a secondary issue, like a very seriously advanced COPD or asthma. So you obviously, PFTs is a must. It tells you whether this disease is related or unrelated to the underlying lung disease. Occasionally, not always, a high resolution CAT scan can help you diagnose lung disease, which also has been implicated in pulmonary hypertension. Right heart catheterization, as I alluded, is an absolute gold standard and a diagnostic modality, so that has to be performed. VQ scan is also very important in the evaluation of pulmonary hypertension, as chronic clots inside the lungs may not be detected by CAT scan and may require a VQ scan, and chronic clots can cause pulmonary hypertension. Next slide, please. So again, a question where which of the tests are routinely used in evaluation of pulmonary hypertension except, and as I alluded in the previous slide, D is the answer. We don't use high resolution CAT scan all the time unless we suspect interstitial lung disease. All the others are very important in evaluation for pulmonary hypertension. EKG is important to know if there's any baseline cardiac condition which may be associated with it. PFTs are obviously important. VQ scan, as I alluded, is important because you want to know whether there's a chronic in the vascular system. And BNP has turned out to be a good biomarker for pulmonary hypertension and is hence what important. Next slide, please. This is a chest X-ray of pulmonary hypertension. I must say that in the last 20 years of practicing pulmonary hypertension, I've never been able to diagnose anybody with pulmonary hypertension just based on the chest X-ray. So the chest X-rays don't appear to be too revealing. And most of the time you look at it in a more 20/20 vision point of view. And if you carefully look at, see that there's a little bit of a hilar prominence, and that's because your pulmonary arteries become wide and dilated in this condition. As I said, again, very hard to pick up if you are not thinking about it. There's some vascular pruning, which again is very hard to pick up. And when the RV gets dilated, you can see this distance between the sternum and the heart also is called the retrosternal space also reduces. Again, something to keep in mind, but this is not going to be your #1 diagnostic tool. Next slide, please. Again, EKG is not diagnostic, but can help you lead towards thinking about pulmonary hypertension. And some of the things you're looking in EKG is basically right atrial enlargement, as you can see with the P waves, or right heart strain, as you can see from T wave inversion in the lateral leads. Next slide, please. And these just mark those areas where the EKG can show abnormalities in patients with pulmonary hypertension. Next slide, please. Spirometry, as I said, is very essential in evaluation of pulmonary hypertension. As I alluded, that some of them may have very severe severe COPD, in which case the pH is related to that, but others may not have any significant COPD, and all they may show is an isolated diffusion capacity defect. Next slide, please. And this is very important to see diffusion capacity defect. In one study, they found that diffusion capacity defect preceded even the onset of symptoms in pulmonary hypertension by 5 years. So if you're serially measuring pulmonary hypertension on a yearly basis in a patient you suspect, you can kind of see the diffusion capacity reducing each year, and that could be another cue for you to hasten the workup for pulmonary hypertension or suspect it. Next slide, please. Another question, patient with shortness of breath for 4 months, echo showing pulmonary systolic pressures of 54 millimeter mercury, which as I alluded earlier is high. Patient had a CAT scan with the P protocol, which is negative. PFTs and EKGs done as an outpatient were within normal limit. So which of the tests below would not be necessary? So number A is a whole bunch of tests for rheumatological connective tissue disorder. As I said, this would be very important because these are the set of patients which have a very high risk of pulmonary hypertension. Number 2, HIV tests obviously will be necessary because pulmonary hypertension is noted to be elevated patient with HIV. VQ scan again is extremely important because patients can be hiding chronic clot in their pulmonary vasculature. And again, D is the correct answer. We don't need high resolution CAT scan. If you look at this patient's history, a regular CAT scan has already been performed. And if it doesn't show any significant changes which would warrant a high resolution CAT scan, then this would be sufficient enough to move forward with the evaluation. Occasionally, a polysomnography is important to rule out sleep disorder breathing. Severe sleep apnea has been associated with pulmonary hypertension, although the pulmonary hypertension doesn't seem to be as severe when it is associated with sleep apnea. Next slide, please. Again, reiterating the importance of VQ scan. Normal VQ scan has a sensitivity of specificity of almost 90 to 100%. CT scan, a regular CT scan with PE protocol can miss chronic thromboembolic disease, and it's very important to do a VQ scan in these patients. Reminder to some of the folks who don't do pulmonary hypertension on a routine basis, patients who have CTAF or chronic clot, they can be completely cured of the disease by surgery and removal of the clot. Is called pulmonary endarterectomy, and it's the only form of pulmonary hypertension. So it behooves us that we do not miss this diagnosis, because this is the only curable form of pulmonary hypertension. Next slide, please. Here's one case of that, a patient who was picked up very smartly by one of our colleagues and noted to have a chronic clot inside the lungs, was sent for pulmonary endarterectomy. And these are the clots which were removed. Patient's pulmonary hypertension completely resolved. He was completely off oxygen and was discharged from the clinic within a year's period of time. Next slide, please. So coming to diagnostic point, I don't want to go in too much detail about it, but a little bit of background information as to what we do in a right heart cath. A swan is basically we float a swan or a catheter, which is a balloon at the end of it, and we direct it towards the pulmonary vessels, and the balloon then wedges, as you can see, toward inside one of the pulmonary vasculatures. Once it's wedged inside, not only can we get the pressures, true pressures in the pulmonary vasculature, but when the balloon is inflated, we can get the pressures from the left side of the heart called the wedge pressure or the end diastolic pressure. So these are very important in diagnosing pulmonary hypertension. Not to mention, we can take a sample of the blood from here, and that is very helpful to calculate cardiac output in these patients. As you remember, in patients who are severe pulmonary hypertension and start getting dizzy, means the cardiac output is being compromised, and we want to know. But that's how we know what medication and how strong a medication to start these patients on. Next slide, please. So the definition of pulmonary arterial hypertension by right heart catheterization at this point is mean PA pressure of 25 millimeter mercury. However, somebody in the audience is probably smart enough to know that the recent NICE classification has alluded that the mean PA pressure of 20 millimeter mercury may be used nowadays for diagnosis, but we are still using 25 traditionally. The wedge pressure, of course, has to be less than 15 millimeter or equal to 15 millimeter. If it is more than that, then it suggests a left heart disease. And your PVR or pulmonary vascular resistance has to be more than 3 Wood units. So these three conditions have to be met. And of course, as you see, these can only be obtained by a right heart catheterization. Next slide, please. This is the NICE classification. Of course, this has been changed, recently again, and it's always a living document and keeps on getting changed. But Group 1, which is called the pulmonary arterial hypertension or PAH, is the one which is very amenable to pulmonary vasodilators and treatment with these specialized medications. So as you can see, we have already discussed majority of these diagnoses and differential. The Group 2 pulmonary hypertension is anything which is due to left heart disease, specifically congestive heart failure, valvular disease like mitral stenosis, aortic stenosis. And Group 3 is all lung diseases, COPD, interstitial lung disease, sleep disorder breathing, and other developmental lung disorders. And group 4 is your CTEPH, as we talked about, the chronic thromboembolic disease, very amenable to surgical resolution. And group 5 is something which we don't have a clear handle on. So we put that in that group. Sickle cell, sarcoidosis, hyperthyroidism belong to this group. So as you can see, the group 2, 3, 4, and 5 need to be treated with treating the baseline condition, while group 1 is amenable to pulmonary vasodilators, and that is how we make a distinction. And this distinction can easily be made with the right heart catheterization. Next slide, please. So it's important to kind of familiarize oneself with some of the pitfalls of this and why it may be important to refer these patients to more centers which doing pulmonary hypertension on a more routine basis. Next slide, please. So one of the pitfalls is that wedge pressure, which is supposed to estimate or be a surrogate marker for left ventricular end systolic pressure, is not as clean a number as we like to think about it. So this is a study done by us, but there are many other groups who have proven the same point, is that pulmonary wedge pressure sometimes tends to LVDP, sometimes as much by average of 4 millimeter mercury, which basically means you can sometimes overdiagnose pulmonary hypertension at the detriment of the patient. So if that happens, we generally have to go back and do a left heart catheterization in order to ensure that the LVDP matches the wedge pressure, and then we are not making an inappropriate diagnosis. Next slide, please. Here's another pitfall which we're noticing in the last few years is most of the cath labs and these systems have become very computerized. And what happens is the computer then tends to take its numbers and average it out itself. And it is very important that there are very respiratory variations to these waveforms when a catheter is placed inside the heart. And these waveforms can change based on your inspiring and expiring. And if there's huge variations, the mean of that could be very different than what we would like to see. And we like to see end expiratory pressures rather than the mean. And these can completely throw people off, and the numbers could be highly erroneous, and you can land up with a wrong diagnosis. So it's very important that labs and centers which do that routinely not only do that, but also document manually these pressures and not trust computers to generate these numbers for you. Next slide, please. And this is an example of that. You can see how much significant variations of respiration is seen on the waveform. And if you take a mean as the computer does, you'll get an answer of wedge pressure of 10 millimeter mercury, as you see on this cartoon graph. Although the right pulmonary wedge pressure and expiratory is 18. And that's a huge difference, because that's the difference between your 1 diagnosis and group 2 to group 5 diagnosis. So patients can be inadvertently wrongly diagnosed and then placed on wrong medication if these pressures are not appropriately measured. Next slide, please. Another important part is vasoreactivity test. Is one thing to float a catheter, get the right numbers, but it's important to know how these people respond to pulmonary vasodilators. In general, we give nitric oxide while we are doing this procedure for about 5 to 10 minutes, generally about 20 to 40 parts per million, and see how does patient react to that very powerful pulmonary vasodilator. So patients with group 2 to group 5, or patients who may respond to just pure calcium channel blockers, have a significant response. However, group 1 pulmonary hypertension patients don't have a much good response. So it's very helpful not only to diagnose, but also to get these drugs approved by the insurance companies who are looking for this vasoreactivity testing. And if you don't have that, sometimes very hard to get these medications approved. Next slide, please. So these are the, in a very general format, 3 major pathways that we treating pulmonary hypertension these days. One, of course, is the nitric oxide pathway. Where you must have heard about medications like sildenafil, which work by increasing the cGMP and nitric oxide and causing vasodilatation. And these are helpful in milder form of pulmonary hypertension. For moderate pulmonary hypertension, we like to block the endothelial receptor antagonist, and there are several medications available which can block preferentially either endothelial receptor A or B or sometimes both. And last but not the least is one of the most powerful tool which we have in our armamentarium is the prostacyclins. And these are very powerful medications and can cause significant pulmonary vasodilatation, and we reserve it for very severe patients. Next slide, please. There have been some recent advances which I wanted to kind of at least allude to you. Next slide, please. So we were always aware that pulmonary hypertension is a little bit different than the regular hypertension we treat. In a regular hypertension, the general approach is, well, patient has blood pressure, let's try one medication. Well, he comes back in 4 to 6 weeks and we say, well, your blood pressure isn't very well controlled. Let me try another one, second one, and then third one. Well, pulmonary hypertension is a little bit different because the mortality is so high. These patients will have a bad outcome. They can have a right heart collapse. We don't have the luxury of time. For many, many years, we have wondered and sometimes even tried, starting with 2 or 3 medications and then lowering it down as the patient gets better. So very completely diametrically opposite approach than regular pulmonary hypertension. And this was validated by a large trial in which they used the combination trial, and they found that patient had significant improvement in pulmonary hypertension hemodynamics, and also had reduced hospitalization and outcome in these patients. So we are using Ambition trial as our guide to do very aggressive upfront therapy in this patient with pulmonary hypertension. Next thing is newer medications like soluble guanylate cyclase, also called as Raxiguat, has now been under trial and has been successfully used for treatment for both CTEPH, which are non-operable, and regular pulmonary hypertension. So another medication which has been added to our armamentarium. But the latest addition has been the introduction of oral prostacyclin. I'll give you a little background on this. Prostacyclins in general are one of the most powerful pulmonary vasodilators that we know, and they're very effective in pulmonary hypertension. The problem with prostacyclin always has been a very short half-life, a half-life of barely few minutes. So because of that, these could only be administered to IV, which had become a lot of problematic for patients who may not know how to deal with IV medications on home, have a pump, and also putting them in some danger because if there was a sudden stoppage of that medication block in the line, these patients could collapse within minutes without having the opportunity to get medical help. So with the onset of oral prostacyclin in pill form, many of these patients are not able to handle IV and advanced medication protocols at home, can now be eligible for these prostacyclins. Both selexipag as well as oral treprostinil have been FDA approved in the last 2 years and have been increasingly used in this domain. So there are significant other pathways which are being currently explored, and hopefully in the next upcoming year or so would be available for treatment of pulmonary hypertension. Next slide, please. As I said, already introduced you to the oral prostacyclin. The 2 which are FDA approved are the oral treprostinil and selexipag. Next slide, please. So with this, I will end my overview of pulmonary hypertension, and the take-home message, as I always said, is early diagnosis is the key. The more later these patients are diagnosed, the less they are responsive to medications and the higher the mortality. If we can pick them up early onset before the right ventricle gets remodeled or right side of the heart fails, they are much more amenable to medication and have a better outcome. Always be beware of the pitfalls of the diagnosis and consider centers which deal with pulmonary hypertension on a daily basis for appropriate diagnosis. And as I alluded in my last slides, there's significant progress being made in the evaluation and management of pulmonary hypertension, which you should be aware of. And with that, I thank you for your patience and be open to any questions from the audience. So I'll open that to the forum.
Thank you. That was wonderful. We super appreciate it.
Thank you.
Everybody, you're welcome to unmute yourself or chat in the question and I can read it for you.
Caitlin, this is Grayson. I did send a message to Dr. Sharma and queried whether or not he typically routinely recommends pulmonary rehab for his moderate, severe, or very severe pulmonary hypertension patients.
That's a great question. And yes, that is a very important aspect of not only pulmonary hypertension, but all pulmonary disorders, whether it's advanced COPD, interstitial lung disease. A lot of morbidity and mortality comes in because of the muscle weakness in the lungs are very heavily dependent on diaphragmatic and extrathoracic muscles and general strength and physical form. So physical therapy and improvement in their overall strength is very important for pulmonary hypertension. Many a times what happens in these patients is because the shortness of breath can be quite extreme, that it kind of becomes a problem in itself. The less the patient walks, the more weaker he gets, the less he's able to walk, and it kind of takes a life of its own. So even when we start them on very powerful pulmonary vasodilators, sometimes there's a mental block in the patient that he just can't walk. And it's not because his lungs not doing well, it's just because he just doesn't have the strength anymore. And I think that's a very important aspect. And we always tell our patients not only go to and get rehab, but also consider constant ambulation at home as much as possible without getting dizzy or compromising their health by overdoing it. So thank you for bringing that up. I think that's a very important aspect of any treatment.
Perfect. Dr. Sharma, I wanted to ask, we have a cardiac echo that goes on, and I just wanted to see if possibly, do you get a lot of patients who can think they have just regular high blood pressure without pulmonary complications? Is that normal, or is that normally not the case?
You mean regular hypertension?
Yeah.
The regular hypertension is a very different disease. It's a very, very common hypertension and diabetes are extremely prevalent around. Just to make clear, the hypertension we are talking here is not the same as pulmonary hypertension. It's a very, very rare disease. So in general, hypertension can worsen the pulmonary hypertension and make obviously the heart work much harder. But in general, there's not much relationship between the two, and they generally don't coexist, and you can have severe pulmonary hypertension. In fact, more severe the pulmonary hypertension you have, the less the blood pressure gets because your cardiac output is compromised at that time.
Great, thank you.
You're welcome.
I have a question. This
Yes.
is Allison Sela. How often are you seeing patients like the one you presenting at age 70 with primary pulmonary hypertension?
Yeah, unfortunately, more often than I would like to, Allison. You know, it's generally is seen more in a younger age group, and I would say because 50% of patients with pulmonary hypertension, at least in the United States, have connective tissue disorder. Patients with connective tissue disorder generally tend to be young because it gets discovered much earlier. So the average age in that age group is around 40 to 45. But it's not unusual for us, for example, patients who had weight loss medication, like some of my patients last week I saw, for this to manifest at least 30 years down the road. So these are the patients in their 60s and 70s that we start seeing pulmonary hypertension. Unfortunately, many a time, the diagnosis get missed. So these patients may have been carrying this diagnosis or this disease for at least 3-4 years before it comes to our attention, which is why we recommend all, primary care physician and our colleagues that if you have even a suspicion, it is worth getting them checked out rather than waiting, because the case I alluded, which is actually still in the hospital, came to us with almost right heart failure. And right heart failure takes a long time to develop. And these patients probably been suffering from it for quite a while and been mislabeled as more common diseases like the asthmas, the COPDs, OSA. And that's another lesson, is that it's a great lot diseases can mimic this disease. So it's very hard to pick it up.
Great, thank you so much. We have a couple minutes left if anybody has any other questions. And if you do think of any after the fact, I can always email them to Dr. Sharma for you. And I wanted to thank you again. That was an excellent presentation. We were very thankful to have you today.
Thank you, Caitlin. Anytime. It was a wonderful audience, and I hope they were able to get some information regarding pulmonary hypertension. And I'll be happy to revisit different pulmonary hypertension later in the year.
Perfect. Thank you so much.
You're welcome.
In the couple minutes we have left, does anybody have anything else you need to talk about or ask?
This is Grayson again, Caitlin.
Yes.
I just want to ask if all of the physicians and respiratory therapists on the call have received a copy of the European Respiratory Society, the ERS's guidelines for doing pulmonary function tests. We are awaiting the American Thoracic Society's guidelines, but the only thing we have now as to how to safely and effectively perform pulmonary function tests, given the COVID pandemic.
Mm-hmm.
I did ask that everyone be sent a copy of those guidelines. I sent them to you, I believe, last week, Caitlin. I just want to be sure that there's no discussion around that, because to my knowledge, only one of the Grayson Dorney Pulmonary Rehab centers has begun doing pulmonary function tests. And I just want to be sure that those guidelines are out there until we get them from the ATS.
And I think that's a great question, and I think that's a question being asked around quite often. And ATS, you're very, very right, Brandy, is coming out with a statement not only just on the PFTs, but reopening of the ICUs, the sleep centers. Hopefully that document should be there in the next week. And I have participated in that document, so I can't talk too much since it's not published at this time. But I'll be happy to come back in a week or so to talk more details about all aspects of our ATS document regarding opening of various respiratory function labs, if you like.
That would be very helpful. And yes, we will make sure that everybody has all of the documents as they come out and everything, and we'll make sure we send that out as a group. I do want to say, not the next session, but the following session, we're going to devote that whole session. It's June 15th. We'll be devoting that whole session to this discussion, to reopening and you know, relearning how to do these PFTs in the new situation. Yeah.
We did open up last week at Preston, and I think we've only done 1 6-minute walk and 1 pulmonary function test, but all of our patients are being tested prior to having any aerosolizing procedures done.
Perfect.
This is Brandy Bell at Lincoln Primary Care. I did perform a simple spirometry test last week for one of Dr. Donahue's patients. He was tested and was negative for the coronavirus, but he actually had to have an emergent aneurysm, abdominal aneurysm repaired, and they had to have spirometry because he hadn't had any PFTs in the last, I think, 2 years. But I was, you know, complete PPE, and he was tested, and it was short and sweet because all we needed was pre-spirometry. But even with that, my workplace was very hesitant about doing the testing. So we still don't have a plan about restarting PFTs at our site at all.
Brandy, this is Grayson again. It's my understanding, and Dr. Sharma may know more, that the ERS guidelines are essentially the guidelines that will be adopted by the American Thoracic Society, with one exception, and that is that HEPA filtration, which is not required by the ERS, will be required by the ATS. Do you have other information?
I think that in general, you're right. These guidelines do mirror each other. The way the ATS, and again, I can't speak on the details since it's still being reviewed, that a lot depends on the prevalence of the disease. In high density areas where there's high prevalence of COVID, there will be a little bit different rules than in a low prevalent area, let's just say West Virginia and others. So the COVID testing and everything depends on the prevalence of the disease. And I think the response also needs to mirror the ground realities of the community where we are practicing medicine. So that's a little bit different in the ATS. You might see a little flavor of that. And I think that sometimes when we are overtly careful and don't follow these rules, sometimes we can get hurt, because we have started seeing on the other end sometimes standard of care being compromised just because of the fear of COVID. So as long as we have that right balance between high density areas and low density areas, I think that would be a theme which you might see in the upcoming document, which may not be true for Europe, since that's a very highly congested area. We are much more spread and diverse country. So, you know, in those lines, I think there will be some changes, but you're right that by and large, we're going to be following the same safety precautions at the European Society and stuff. Hope that helps.
Thank you. It's very helpful. So everybody, we have reached the end of the time. Dr. Sharma, thank you so much again. Our next meeting is on June 1st, and Dr. Zulfikar is going to come and talk to us about air quality epidemiology. Everybody look for the recap and all of the reminders. And everybody have a wonderful week.
Take care.
Thank you. Thank you all.